All right, Chapter 25, Suicide and Non-Suicidal Self-Injury. Some of this is going to feel really basic, guys, but we have to talk about it. Intentional act of killing oneself by any means. So we have a couple of different statistics here for you. It's the 10th leading cause of death, the 4th leading cause of death among children aged 10 to 14 years, the 3rd leading cause for 15 to 24, 4th for 25 to 44, and 8th for 45 to 64. Refresh on box 25-1, page 482 on suicide facts, okay? That's going to be important for you to go through. So risk factors for suicide, you'll notice that psychiatric disorders are there at the top of that list. Alcohol or substance use disorders. Male gender, they commit suicide 4 times more often than women. So when we learn about depression, we're going to find that women tend to be much more depressed than men, and it's a risk factor for depression, but being male gender is a risk factor for suicide. Increasing age, so males peak after 45 and women after 55, and then there's other lists there. These are just outlined right from your book: race, religion, marriage, profession, physical health. There's a suicide risk assessment score in your book. Make sure that you go through that. So biological and psychosocial factors, suicidal behavior tends to run in families. Low serotonin levels are related to depressed moods, so we'll end up talking about that as well when we get back into depression. We've done a lot of stuff with the SSRIs already in pharms, so we'll talk more about that, and we know that those can increase serotonin levels. So Freud said that it's aggression turned inward. Menninger, these are different theorists that said what was happening for people that wanted to commit suicide. Menninger says that they wish to kill, wish to be killed, or wish to die. Aaron Beck, it says central emotional factor is hopelessness, all or nothing thinking. So think of those cognitive distortions that we just did in the last video with that all or nothing thinking. And other recent theories, it's a combination of suicidal fantasies and significant loss, as well as copycat suicide. So we now have that, another thing to watch in people who have someone who just recently committed suicide for copycat suicide behavior. Cultural factors, so some cultures have protective factors. So African Americans tend to have a high role or place a high value in extended family and in religion, so those are both considered protective factors. Hispanic Americans, the Roman Catholic religion and importance of extended family, so again, pretty much the same thing. And then Asian Americans, the adherence to religions that tend to emphasize interdependence between the individual and society. Remember, we just learned about Eastern culture and how, there was an emphasis of depending on others and working in the family unit, or, working as a whole instead of having your individual identity. Other things to be aware of: white, non-Hispanic have the highest number of death by suicide. And then another new thing it's not new, but it's been more recent in the past, 15, 20 years, is suicide bombers, because that didn't used to be really a thing. And now we have suicide bombers, people killing themselves for a cause, and taking out other people with them. So societal factors, so there's different things that, in here in the United States and other countries we have as far as suicide and being accepting of suicide. So Oregon's Death with Dignity Act of 1994, terminally ill patients are allowed physician-assisted suicide. And just a couple years ago, and I don't know her name off the top of my head, but I'm sure some of you will recognize the story. There was the younger lady who she was in her 20s, and she moved to Oregon to be able to participate in the Death with Dignity Act, and she was able to choose when she took the pills that they prescribed to her, and she just went to sleep and died. So that's something that Oregon does have for those who are terminally ill. They can be prescribed a lethal dose of, I'm not even sure what it was. I know I could look it up, but not at the moment. So anyway, Washington State physicians can prescribe lethal medication. The Netherlands, non-terminal cases of lasting and unbearable suffering. Belgium, non-terminal cases when suffering is constant and cannot be alleviated. And Switzerland has had assisted suicide legal since 1918. So, that's something new. It's one of those things that we look at as an ethical dilemma because we all kind of stand in different spots when it comes to this sort of thing. So just FYI for your information. So application of the nursing process. This next part is going to be important for you guys to understand. So verbal and nonverbal cues that I can get from my patients. So you have overt and covert statements, right? Overt is like, I can't take it anymore. Life isn't worth living. I wish I were dead. Everyone would be better if I died. Okay, all those things the patient is flat out telling you that they're suicidal. But then you have covert statements like, it's okay now, soon everything will be fine, or things will never work out, I won't be a problem much longer, or how can I give my body to medical science? I mean, if the patient is asking these kind of questions, we need to delve further in and see if something is going on with our patient, if they have some suicidal thoughts going on. And the part that becomes tricky with this is that, it's not a societal norm to ask or press somebody. It just, we would feel uncomfortable. So we would just provide silence during that, which would not be actually a good thing to do. So we have to get comfortable with saying, what did you mean when you said, I can't take it anymore? What are you talking about when you say things will never work out? You have to make sure that you ask your patient these things. If not, you may be the only thing that stands between them and taking their life. So we have to get out of that uncomfortable zone that we're in. So we also need to work on or figure out what the lethality of the suicide plan is. Okay, so I want to ask myself and the patient, is there a specific plan with details? How lethal is the proposed method? And is there access to the planned method? So there's hard and soft methods. Now, in a minute, when I say the soft methods, that doesn't mean they're not effective. They can definitely be effective. Typically, however, and not always, but typically, soft methods are more of a cry for help. But not always, and people are successful with soft methods. So just because somebody uses a soft method doesn't mean they're not serious. All right, so don't automatically jump to, oh, they slashed their wrist, so that means that they were just crying for attention. Many times they're crying for a hand of help. They're not just looking for attention. They need help. So, but the hard methods, these methods are methods that typically are going to be successful. So using a gun, jumping off a high place, hanging, poisoning by carbon monoxide, or staging a car crash. Soft methods include slashing of the wrist, inhaling natural gas, and ingesting pills. So, but again, please do not take it as just because a patient tried a soft method doesn't mean that they're not serious about their suicidal ideation and going through that, okay? So just keep that in mind. This right here is a sad person scale. This is in your book. It's the 10 major risk factors to assess suicidal potential. And so the person gets a score for each one of these. So you have the male sex already gets a 1. If they're age 25 to 44 or 65 and older, they get another 1. Do they have depression? Do they have a previous attempt? Do they drink alcohol? Have they had rational thinking loss? So social supports are lacking, or a recent loss of some type. And recent loss doesn't mean just somebody died, though, guys. It can be a loss of a job, a loss of, yes, a loss of a loved one, but a loss of a relationship. So a recent loss it can be more things than just death. Do they have an organized plan? Do they not have a spouse? So if they're single, that gives them a risk factor. And do they have some type of a sickness? Are they sick? So then over here you have your your scores at the bottom and what needs to happen. So a score less than 2, discharge with outpatient psychiatric evaluation. A score of 3 to 6, consider for hospitalization or at least very close follow-up. And a score of 7 or greater, the patient needs to be hospitalized. So there's there's not a lot of wiggle room with this. Although I will say it's obviously it's going to depend on what the patient is being seen for, because I realize that a single male who is a certain age would automatically score 3. So unless they're being seen for some kind of psychiatric or depression or that, we'll have to use a little bit of common sense when it comes to that. But excuse me. But if it's going to depend on the situation in which the patient is in that we're giving the score and what we're going to do with that. So application of the nursing process, the diagnosis we're going to use here is a risk for suicide. This is the highest priority. Remember, safety is at the top of the list here. My outcomes identification is going to be suicide self-restraint. So I don't want my patient to try to commit suicide. Implementation, there's different primary, secondary, and tertiary things that we can do for the patient, which we're going to talk about here. So the levels of intervention, primary activities, primary prevention are activities that provide support, information, and education to prevent suicide. So there's a QPR, which is question, persuade, refer. You want to use that in order to try to help the patient get the next level of intervention that they need. So I'm asking them, I want to persuade them not to, and I want to refer them and get them in somewhere. Secondary, so the treatment of the actual suicidal crisis, so hospitals, jails, telephone hotlines. I mean, we're just looking to get them safe in whichever way that we can. And then tertiary, so this means that the patient has actually committed suicide. So interventions with a circle of survivors left by individuals who completed suicide to reduce the traumatic after effects. It's very important since suicide rate increases for those that have experienced a loss from suicide. So my primary and my secondary levels of intervention are for the patient. My tertiary is for the people that are left behind. All right, so it's important to remember that. So interventions we can do are teamwork and safety. Remember, we've talked about one-on-one, every 15-minute checks, Q1 hour checks, counseling, a no suicide contract or a no harm contract. And this is done quite often in psychiatric facilities, that the patient will actually sign something saying that they will not harm themselves. And I get it, it's just a piece of paper that they've signed, but it's also something that they've committed to somebody else. So they actually are quite successful, believe it or not. Health teaching and health promotion, specifically community resources, things that I can refer the patient to try to help them. Case management, pharmacological interventions. Is the patient cheeking? I need to make sure that they're not getting worse because they're not taking their medications. And then antidepressants. But remember, specifically with my SSRIs, because we're going to use those the most, that if the patient, that we need to educate the patient that if they become worse and their suicidal thoughts become worse, that they need to most certainly let us and the provider know so we can get them switched to something else. Because again, I don't want them sitting around thinking that everything's just so hopeless for them. And then postvention for survivors of completed suicide. Remember, the survivor is the patient now, not the deceased. So we need to focus on their coping and what they're going to do, not what the patient did. Surviving family may experience overwhelming guilt and shame. Family members are 4.5 times greater risk of suicide than in families where no suicide occurred. And please be sure to read page 493, the survivor of a daughter who committed suicide. It's a good, quick story for you guys to read to understand what a person goes through after their loved one commits suicide. So non-suicidal self-injury prevalence, this typically begins between 10 to 15 years of age. The lifetime prevalence is 13 to 23% for adolescents. So this is cutting, basically. Comorbidities that can contribute to things like cutting is borderline personality disorder, anxiety, and substance use disorder. Etiology, so there's biological factors, there's cultural factors, and there's societal factors. Specifically with the societal factors, the book talks about a social phenomenon that now, that we have, it's on a rise of our younger people that are cutting themselves. And so if I'm young and I see somebody else doing it and it seems to be relieving something in them, maybe it'll relieve something in me. So this was just one of those questions: which method of suicide has the highest lethality? And so it's going to be a hard method. Two of those are soft methods, one of those are hard methods. All right, that's it.